Most residents they know in management of intermediate uveitis with a list of drugs, steroids, immunomodulator therapy, and biologics. That's it. Hello PGs, welcome to my channel Ophthal Exams and Viva. Today I am going to connect two words, COTS, COTS guidelines in ocular TB and major intermediate trials like POINT, SAMIT, etc. By the end of this video, intermediate uveitis management will feel logical. Let's start. So in my last video, we discussed the investigations and treatment approach to intermediate uveitis. If you haven't watched that yet, I strongly recommend seeing it first. It will make this video much easier to understand. Now let's begin with COTS. What is COTS? COTS is the Collaborative Ocular TB Study. Residents often misunderstand this. So before I start COTS, residents should know that COTS is not a diagnostic criteria. It is mainly a treatment-based framework. So I'm going to discuss about COTS. COTS is mainly a treatment-based framework and it is mainly for tuberculosis cases. So we'll discuss what, why and how it should be applied and how does it decides the treatment. And next we'll go on to the treatment trials for various drugs. So what is COTS? COTS, it is an international expert concessions project. So in India, where TB is endemic, this becomes extremely important. So before COTS, it was such a great confusion that when should ATT be started or what are the tests that we should follow. So an international expert concession project was taken to standardize when to start ATT in tubercular uveitis. So this is particularly for cases with TB uveitis, right? So why was it considered? Because as I have said that before COTS, people were either over treating it or the treatment was delayed. Thus, this project was taken. I have told you it mainly applies to tubercular uveitis and all types of TB uveitis, be it anterior, intermediate, panuveitis or TB retinal, tuberculosis retinal vasculitis. So, how do we apply it? So, if it is the first episode, you know what are the tests we discussed for tuberculosis? So, we discussed Montu test or QTB gold test, or we can say interferon gamma release assay and radiological test. Either you go for chest x-ray or HR CT of chest, right? So if it is the first episode and suppose your these tests QTB came positive and radiology has some findings, so both findings have to be taken together and then only you go for ATT. It is moderately recommended based on this COTS. COTS say that if the case is recurrent, so even if one of these tests is positive and it is endemic country like India, you start ATT. You keep the threshold low for starting ATT. So it is strongly recommended in recurrent cases with any one of these two tests positive, and if you think the clinical picture is also of tuberculosis, start ATT soon. Then what are the role of steroids? So we know that uveitis, people directly start with steroids, but it is very important to rule out TB first because in TB without ATT cover you cannot start steroids. Steroids have to be given under cover of anti-tubercular therapy. So this part is very important and this should be remembered for exams, for Viva and for clinical management of the patient. So we are clear that COTS and SUN classification, standardization of uveitis nomenclature. So COTS mainly decides treatment algorithm, whereas SUN classifies and grade the uveitis. It is mainly for tubercular uveitis, whereas SUN classifies all type of uveitis. Okay, so what is important here is, especially for Viva, that the collaborative ocular study, it describes TB uveitis as an entity that satisfies the clinical presentations of IU along with diagnosis of TB, and this must be performed on exclusion of other uveitic entities, which is based on the clinical manifestation of the disease, which we have already discussed in my last video. In addition, it is suggested that tubercular intermediate uveitis usually presents bilaterally because it's a systemic disease and it has severe vitritis also. So if it intermediate uveitis, bilateral vitritis, and if the posterior synechiae are mainly broad based, if it has broad based posterior synechiae, granulomatous capies, then the picture looks like of tubercular uveitis. Then you go for these tests and decide based on the recommended treatment. If there is a strong recommendation for ATT, go for ATT cover and then steroids of the patient. Okay, so next we start on the treatment of intermediate uveitis. We will just see that how these trials they change the practice in treatment of intermediate uveitis. So before I jump into the trials, you remember one simple concept, that intermediate uveitis treatment, it has three pillars. You are aware that steroids, immunomodulator therapy and biologics, and now we will expand. So let's start at the base, which is local steroids. Now, if we talk about local steroids, they are mainly given in cases which are intermediate uveitis with vitritis and plus minus cystoid macular edema. So there was a point trial which said that periocular versus intravitreal corticosteroids, right? So it compared, now it is written the trial only, it compared periocular steroid, which was a triamcinolone acetate, with intravitreal corticosteroids, which were dexamethasone and triamcinolone acetate. So these two were intravitreals and periocular TA, which was given as PST. And they found out that intravitreal steroids, they controlled CME faster than these periocular drugs. So today we specially go for intravitreal dexamethasone or TA early in uveitic CME. So point study mainly focused on the root. So it is important that you go for intravitreal steroids early in uveitic CME based on point trial, right? Now imagine a patient with chronic recurrent IU. So instead of giving him steroids again and again, we start with steroid sparing immunomodulator therapy, and this was given by SITE trial, which is systemic immunosuppressive therapy for eye disease. Systemic immunosuppressive therapy for eye disease. So it compared 4 drugs: methotrexate, azathioprine, mycophenolate and cyclosporine. These 3 antimetabolites and 1 cyclosporine as T cell inhibitors. So SITE mainly showed that it worked on the long-term efficacy and safety of MAMC. So it showed that all of these drugs are safe and effective. So the mindset shifted from steroid dependent to steroid sparing drugs. That means you can start patient on early immunomodulator therapy if the case is chronic and recurrent. Now, next question comes, which immunomodulator therapy is better? So another trial was FAST trial, which compared methotrexate and mycophenolate, and it came out with methotrexate as the first line drug because it was effective also, and it had less side effects and it was cost effective also. So methotrexate is cheaper, accessible, and that's how it becomes the first line immunomodulator therapy for intermediate uveitis. Now suppose if the disease is severe, bilateral and refractory to immunomodulator therapy also, then we use biologics. Okay, so if it is very severe and refractory to immunomodulator therapy and it is non-infectious cause, then you go for biologics. So one study was done visual There it had different parts 1, 2 and 3, and visual triad showed adalimumab significantly reducing treatment failure and flare rates. So visual trial mainly defined when TNF alpha inhibitors becomes a part of intermediate uveitis algorithm. Now suppose if the disease is severe, bilateral and in young cases, and you want to achieve long-term control for the patient. So you cannot keep on giving one injection or every time intravitreal injection whenever he comes and you go for intravitreal injections. You need a long-term control for these patients. So there was a must trial which compared systemic versus implants. Implant mainly retisert, which was intravitreal triamcinolone acetate, and it said that both had equal efficacy, but the only difference was in side effects, that implants had more side effects as compared to the systemic drugs. So if the patient want long term control and is young, go for systemic treatment for the patient. Okay, so next, cystoid macular edema therapy. So most of the residents, they know that for cystoid macular edema you go for anti-VEGFs, right? But in intermediate uveitis, this cystoid macular edema is mainly inflammatory, so you need to control the inflammation. So based on merit trial which compared steroids and anti-VEGF, they came out with the result that steroids are more effective in uveitic CME as compared to anti-VEGF. Obviously, they have no role because VEGFs are not there. It is mainly inflammation you need to control, and steroids are the best intravitreal drugs to give. So, wow, beautifully we have covered all these trials. So, you need to remember is point trial, local steroid choice, site trial, that you start immunomodulator therapy early, fast trial, that methotrexate is the first line drug, visual trial, that when to escalate to biologics like adalimumab, must trial for long term strategy you go for systemic treatment as compared to implants, and for uveitic CME prefer steroids and not anti-VEGFs. So if you remember only these 5 lines, you can answer the most intermediate uveitis management questions in Viva, and this table you can make in your exams as well. This will take just 3 minutes to make in it exams, and you can score better than others because not everybody is going to mention these trials and mention the treatment like the way I have shown you. Now I just again tell you, ultra stat questions for Viva. So very, very important question is that what do you prefer in cystoid macular edema in intermediate uveitis? That you should know that go for early intravitreal involvement in uveitic cases. If it is unilateral early first or second episode, you can go for periocular injection, but it is better to go for intravitreal injections first. Second, they ask that which is the first line treatment taken as immunomodulator therapy. So you should know about methotrexate. Now biologics, they ask for TNF alpha inhibitor. You should be aware of adalimumab. And trials mainly point trial and site trial, and COTS, which I explained you. So just remember this table and you are through with the management. Now that we have connected COTS, now we have connected major trials of intermediate uveitis, and on it, this is something most students struggle in real practice. This I have given you very nicely. Do we continue medical therapy, and when do we actually consider pars plana vitrectomy? So I'm just going to give you 2 minutes exam oriented knowledge for PPV in uveitis. Okay. So in intermediate uveitis, not only the inflammation part is there, but in later stages when complications are more and become severe, there is a structural damage, and for which we have pars plana vitrectomy in intermediate uveitis, or we call it MIVS now, which is microincision vitrectomy system. So little bit about history. that in 1971 Matchmers, ये वाइवा में भी पूछा जाता है, so you need to remember this name, who first introduced vitrectomy was Matchmers, right? Followed by O'Malley and Hines 20 gauge PPV. Initially, this name was given to MIVS, transconjunctival sutureless vitrectomy, eventually named as MIVS, which is microincision vitrectomy system. Now in 2002, 25 gauge came, 2005, 2010, 2002, 25 gauge vitrectomy was introduced, in 2005, 23 gauge vitrectomy was introduced, and in 2010, 27 gauge vitrectomy was introduced. Now important part is these inner diameters. These diameters are asked in Viva. So you need to remember this. It is very, very, very important for Viva. You need to know the diameters of these vitrectomy system. Now, the conventional system, it had this cutter large in size, but now in MIVS, this cutter port is smaller and closer to tip, if you see, to decrease the complications of pars plana vitrectomy. Now, we will discuss pars plana vitrectomy as a separate topic in my other video, but here I am just giving you one page knowledge for MIVS to write in your exams, and what are the Viva questions asked related to intermediate uveitis and PPV. So here you just need to remember that PPV in uveitis, it has mainly two roles. One is therapeutic, ठीक है, काट के सारा बाहर ही निकाल दो. Vitreous opacities are also out, inflammation load is also out, especially it is done in recalcitrant or recurrent intermediate uveitis. And another important role is diagnostic. This is very important. So how do we go for it? That you collect undiluted vitreous sample and you send it for different tests that we already discussed in my last video. Now, initially this diagnostic MIVS was done and three ports are introduced into the globe. First is infusion, cutter and endoillumination. How will you remember this? So you remember this mnemonic, eyes. So eyes, vitrectomy में eyes डालते हैं. Eyes क्या है? Infusion, cutter and endoillumination. So initially, because of this infusion, there was a risk of hypotony because the infusion was kept off to avoid dilution, because we want undiluted sample. So eventually perfluorocarbons were used in infusion port, but very expensive product to use. So nowadays a continuous air infusion is used while taking out the sample, though it has a side effect, Fisher phenomenon, but if the surgeon is trained, the side effect is very less and we get the 0.5 to 0.1 ml of undiluted vitreous sample. Now while taking out the sample, the cut rate should be low. Now the cutter remains open for longer time and you can get a better bite, but there is a risk of traction here because cutter remains open for longer time and it is cutting, so traction can be there, retinal tears can be there. So some books mention that the cut rate should be higher and it with lower suction rate. So that's how you can go. So both are correct and it depends on the surgeon how to use it. Like one of my juniors, he just taught me what was taught in his VR surgery class, that the cut rate should be kept low to avoid damage to the vitreous cells, and you can send fluid bag also post VR surgery for biopsy. So it's a very good learning because nowadays teachers are only the examiners and examiners expect this answer only. So it is better that you give this answer, but if he expects more, you can explain everything like what I have just taught you, right? So now we have completed our answer on intermediate uveitis, starting from my first video on intermediate uveitis, starting from definition to etiology to investigation to management, and now these trials like COTS and medical treatment trials from point, site study, etc. and going on to the surgical part also, like PPV in intermediate uveitis. And this is how you write a complete answer and you prepare for your Viva also in just 1 or 2 videos. So, all the best. If you have understood today's guys, you have understood the medical management of intermediate uveitis. Thank you so much. Comment below for the next topic. तब तक